Hello, I'm Victoria Emerton, and welcome to Behind the Design, brought to you by Design and Mental Health, the leading in-person event connecting professionals from around the world who design, create, manage, and deliver care in the built environment for mental health care. Design and Mental Health takes place in the UK each June and features a comprehensive programme of presentations, panels, and workshops, a free-to-attend exhibition of specialist products and services, and the prestigious Design and Mental Health Awards. The event website, designandmentalhealth.com, has all the information on the event dates, the programme details, and how to book your event passes. Today, I'm delighted to be joined by Frank Pitts, Principal at Architecture Plus. Welcome to Behind the Design, and thank you for your time today.
Oh, thank you. I'm delighted to be here, and I'm looking forward to being in Manchester.
So Frank will be giving the presentation together with others, and the presentation is called The Reinvention of Mental Health Crisis Services, a Conversation. And Frank will be accompanied by Scott Zeller and Jane Grassi. Scott is from the States and he works in emergency psychiatry, and Jane is from Scotland and she works as an attending in emergency medicine. So we're going to be talking about that presentation today. So what are mental health crisis services, to start off?
It's a field that's defining itself, although I should say that it's finally come round to defining itself. Traditionally, psychiatric emergency, mental health emergency was what happened in an A&E or in an emergency department in the United States when someone in a psychiatric crisis made a presentation. And traditionally, in a traditional emergency department, there probably wasn't a psychiatrist attending. And so there would be a lag in getting care, sometimes a horrendous lag in that the location actually didn't have anybody that was capable of providing psychiatric care. And so what's happened over the last 20 years in the States is the proliferation of a diversity of efforts to create services that would better handle people who are in crisis, in psychiatric crisis or mental health crisis. And those range from, and bear with me just for a moment, because it is a diversity, and that diversity is part of what's confusing. It ranges from mobile crisis teams that are out in the community with specialists who are seeing people on the streets in major cities in America and providing care, and frequently are the folks in the systems that have them that bring people to crisis service rather than a first responder like a policeman or a fireman. It ranges at the other end to crisis residential services for someone whose caregiver is not available to them. Someone's caregiver, someone's anchor has gone to hospital themselves or needs a respite and goes on vacation. So in between all of that is a diversity of things that go from urgent care centers in the community to the interesting thing that we're going to be talking about, which is what's happening in general hospitals and what's happening in freestanding crisis centers, where a diversity of competency is being presented or provided, directed explicitly at providing mental health care for people who are in crisis. It's been interesting to experience this, Victoria, because I used to say, if you've seen one psychiatric crisis center service or mental health crisis service, you've seen one. There's every one that we've worked on between the year 2000 and about 4 or 5 years ago was slightly different. And they weren't regulated consistently. The regulation would change from state to state. There was no national regulation for them. And it's only been recently that things have started to coalesce into an understanding that there are different levels of crisis service and that they need to be regulated and described and identified differently in the United States.
It sounds complicated. So why are these services described using so many different terms, and why is it so difficult to define them more precisely using common terminology?
In part, in part, it's because there were a series of experiments. People were trying in their community a new or a different thing or a new or a different way of providing this level of care. So Scott Zeller, who we'll be interviewing, is now pretty well known internationally for pioneering a particular approach to crisis services, and it's called an empath unit, um, empathy empath unit, or emergency path unit, um, and Scott. I think I first became aware of what Scott was doing uh, 12 or more years ago, easily. Could even have been earlier. He had pioneered something in Alameda County, California, called the Alameda Model at the John George Hospital, which was a very interesting environment for care that was dedicated to the to caring for folks that were experiencing mental health crisis, in an open milieu. Um, and it was very different from what was happening in a traditional emergency department, in that the care was centered on crisis services for folks that were in a mental health crisis, with medical care and the capacity to handle a wide range of medical problems in addition to the psychiatric presentation. Um, his model has salience in the United States, and I believe it will have salience, or starting to have salience, in the UK. In that it addresses two or three problems simultaneously. One problem is that folks who show up in an emergency department with a mental health crisis frequently are very difficult to take care of within the competencies that exist in most A&Es and emergency departments, unless they have psychologists, psychiatrists in particular, and trained psychiatric nurses that are available and present. And so the quality of care can be a problem, and Scott's model deals with that. Um, the other thing that happens is that in the traditional model, people end up boarding. They end up staying up to 24 hours, and frequently more, although it's a dirty secret, they're not supposed to, but they stay for very long periods of time in beds that could be used by other patients who are suffering from an emergency that's not psychiatric, um, because they're waiting for a place to place those patients. Um, uh, or they're waiting a good long time to be able to do a do an assessment. And so it takes those patients out of a traditional emergency department, and treats them on a separate track, allowing the emergency department beds to churn more regularly, which has significant implications for the efficiency and financial success of a traditional somatic medicine emergency department. And then the third thing that happens in Scott's model, and I will say that this is the model that actually is emerging in parallel with Scott in other places, with other names, with other ideas, where treatment is being provided almost immediately. It isn't just about assess, stabilize, and then get them somewhere and hold on to them until you can figure out where to get them. In Scott's model, you begin treatment right away within the open milieu, and within those emergency settings. Um, I think I forgot the question, but I hope I answered.
We're talking about describing services in lots of different terms, and why it's difficult to
Oh,
define them using common
yeah.
terminology.
Yeah, and so what's been happening, is that 4 or 5 years ago, the federal government in the United States determined that psychiatric emergencies was a crisis, systemically across the country, something that needed to be addressed, and wrote a series of recommendations about things to do. And people began doing those things, um, um, with without there being an overriding definition for the individual sets of things, independent of where they were situated. And Sam said just recently, and Scott just shared it with me this week, and I first heard about it maybe 3 weeks ago, has now very precise definitions about levels of care and an understanding about the settings and the staffing that's necessary for those levels of care. And I think that that nomenclature, that now a national nomenclature, will help clarify things. You have to understand that with when we started doing this, I think our first crisis service was probably planned in the year 2000. And at the time, in 2008, we probably did our second one. And at the time, there were only something like 20 crisis services, psychiatric crisis services in the country. Today, there are ranging from 120 to 160 is what I've heard. And they're really multiplying rapidly. So when there were so few, it wasn't necessary to be particularly precise. Let the experiments happen. But now that there are so many, precision actually becomes important, especially if there's going to be funding, and especially if there's going to be regulation about the level of care that's being provided in the different types of settings. So there's finally a need to do it.
And I guess having some sort of sets of standardization definition helps with benchmarking, just making sure everybody's at a level that they need to be at. So it's constantly evolving, even though to me, for the size of the states, 160 facilities still doesn't sound like very many.
So this is dedicated psychiatric crisis services. And so they take many forms. And this is not dealing with residential crisis services or urgent care or walk-in, or the kind of crisis services that are embedded in a traditional A&E or an ED, where there may be one or two rooms that are reserved for folks in psychiatric crisis, but that are used at other times for other purposes. These are services that are at some level providing meeting some level of EMTALA requirements, a capacity to care for more than the mental illness, with a medical model, and located, so they're intensive and they're located either in the community or at hospital. That's what we're focusing on now in the conversation with Scott and Jane.
So I'm really excited that you're bringing this session to Design and Mental Health in Manchester, and you're bringing physicians, boots on the ground, people with direct experience. So why did you propose this topic and select these two experts as your panel?
Because I thought that we'd finally reached the point where the design professions needed to begin to understand the clarity that was starting to emerge within the medical professions, that it would also be helpful to understand what the differences were or the similarities were between the United States and the UK. And these two in particular, because I've known Scott for years, and I'd heard that Scott was in Scotland. Oddly, and that he was spending some time in the UK talking and lecturing, and that Jane had been did a fellowship in the United States at an empath unit in Minnesota, and I thought, well, we have two pioneers here, one from each country. Each is familiar with the other and with their work, and who better to talk about this than the two of them?
Amazing insights. I'm sure they'll be able to bring to the event. So you're going to be at the event for both days, aren't you? And I'm sure you're very happy for anybody to come and seek you out and talk to you, before or after your session, to really get under the skin of what it is you're covering and how they can learn from you.
Absolutely. Glad to talk to people.
Fantastic. That's what all being in the same place is all about, isn't it? Talking to each other and learning. So Frank will be at Design and Mental Health, taking place on the 3rd and the 4th of June in Manchester. If you want to talk to Frank and his colleagues and anyone else talking on the programme, please do come along to Manchester and join us. As I said, the event website is designandmentalhealth.com. You can find all the information on event passes and details of how to get there, etc. On that website. So it's been really interesting to talk to you today, Frank. Thanks so much for your time. I'm looking forward to seeing you quite soon. Design and Mental Health is not far away as we sit now. So we look forward to seeing you, Frank, your colleagues and everybody watching this podcast in Manchester. And again, thank you so much for your time today.
Thank you for having me here.